Thank you, John. So we're going to move on to our first speaker now, Dr. Aoibhinn Walsh. So if Aoibhinn wants to come up. So I'll just give a little background on Aoibhinn, and then she'd probably go through a lot more of that within her presentation. So Aoibhinn is a consultant paediatrician with a special interest in inclusion health. She is the founder, principal investigator and lead clinical researcher of the Lynn Clinic, which supports inclusive and equitable healthcare delivery to paediatric populations experience social adversity. For example, children who are homeless, refugees and international protection applicants. Also ethnic minorities who experience difficulty with engaging with healthcare service. So Aoibhinn has always had an interest in healthcare delivery to marginalised children, which was strengthened when she went overseas with Médecins Sans Frontières to work as an expat paediatrician. Her current clinical focus is on the establishment and future planning of a paediatric inclusion health service within Children's Health Ireland and the HSE to formalise care pathways for children at risk of social inclusion, with a strong focus on a robust system of care between hospital and community health and social care practitioners. So we're delighted that Aoibhinn came down to us in Sligo today and that we can learn from some of her expertise today. Thank you.
Thank you. Thank you. Thank you so much for inviting me today. It's such a pleasure to be down here, and I think it's really good to talk about this, to actually be at a conference talking about these children and these families who are really invisible. We see numbers in the news and we see numbers of reports and statistics, but actually you look at each child and each family as a unit and a person, and actually having a public format to discuss this and to recognise it as an ongoing challenge and a big problem that we're at the moment not really managing as a society and a country to deal with in a very holistic manner. I think having people come here to talk about and discuss, I've already chatted with Shirley already about a pathway that I think we need to plan for some of the children living within the IPAS system. And it's great to meet people, to get to know people who are interested in this area and learn from everybody's expertise and experiences, because there are differences between what I would experience in Dublin versus the more rural and isolated settings in the west of Ireland, and to kind of know that certain approaches I might take might not work for the communities that you're involved with, but equally trying things and discussing and sharing the information is what we're here today. So I'm going to talk about healthcare delivery to children experiencing social exclusion, and I'm going to talk about it in the context of the service that we run in Temple Street, which is the Lynn Clinic, which is our community outreach clinic for children experiencing social exclusion. But it's talking about how we established that clinic, why, what works, what hasn't worked, and what we hope to do in the future. And I think we are seeing numbers in Dublin in terms of children in homelessness and children in congregated settings through direct provision that are exponentially increasing. And there's an opportunity here, I suppose, to start to establish something maybe a little earlier on than we did in CHI, and maybe start to try to catch up with what we need to be doing. So just talking about, when you look at the WHO Sustainable Development Goals, reducing health inequities and improving health for all requires cross-sectoral work and a strong local and regional engagement. And to know that there's multiple agencies here. During my training, I suppose, you very much get used to being in this ivory tower of an acute hospital, and you see people and you do a lovely plan and you write a lovely prescription and you'll say them in 3 months and everything's lovely. You have no idea what they're going out to, and by and large they'll come back in 3 months and nothing's changed, and you'd be scratching your head going, but I did everything. So I think we need to talk about, as much as part of the medicine is the medicine, I say the medicine is the easy bit of what I do. Because a lot of the children coming to me are very sick, and they're sick with natural history of disease processes, and I can very easily identify the medical challenge and the treatment or the management, but it's navigating around all of the other barriers and the social determinants of health to actually support an optimal health outcome. That is the challenge. So I love this quote. It's Maya Angelou: "There's no greater agony than bearing an untold story inside you." And that's sometimes something we see when we meet these children and families, because you can break something down to the kind of jigsaw piece puzzles, the asthma, the constipation, the developmental delay, but actually you need to look at their story and what's brought them to the place that they're at today, that you're in this clinic that needs to support people and give them that bit more scaffolding. And sometimes we hear the untold stories and sometimes we don't, and I'll talk a little bit about that later on. But I think to have the awareness that there's often a huge amount more going on with these families, sometimes single caregivers, sometimes real generational trauma and deprivation, that you have to meet people where they're at. And sometimes they're not ready to engage with the beautiful plan you've created. And that's okay. And sometimes we give an hour to the children and families coming to our clinic for a first appointment. Sometimes at the end of an hour, we haven't actually even gotten to the medical piece. Someone might just divulge something or disclose a really significant history of domestic violence or sexual or gender-based violence in a caregiver, and you just let them speak. And you get to know that piece of their story, and then you just bring them back in a month and actually get, recognize that the child's weight is okay, there's nothing urgent, and bring them back in a month to start to go through the other pieces, not rushing people and trying to meet them where they're at and what they feel comfortable divulging and discussing as well. So these are some of the key concepts. They might be very familiar to many of you, but I suppose I'll discuss them with a little bit of a tailored lens towards the children that we meet. So we all know that social exclusion is people living beyond the margins of established societal infrastructures, be it healthcare, education and housing. And all the unique kind of unifying factor of the children that we see is they are all experiencing really significant social adversity. 87% of the children who I saw in 2024 were in homeless accommodation or emergency accommodation of some iteration. So that's another big kind of unifying factor, I suppose, is that congregated setting, and that people say, lack of housing, and we'll often say lack of accommodation, but it's lack of home. And it's not just the accommodation piece, it's all of that security and that, literal and metaphorical warmth and that safety that a home provides that they're without. Something we see a lot in the North Inner City Dublin is intergenerational disadvantage. So about 20% of the children I see are born and bred in the Northeast Inner City, generations of family living in the same area. Most of them are now in single parent families or living with grandparents because one of the parents might be dead, one might be street homeless, dealing with significant substance misuse, or the child is in foster care under TUSLA. And you see the real impact of that generational poverty in the North Inner City. But what you also see there is an incredible community. You really see people, there's a tour, and I highly recommend if you go up to Dublin, there's a tour by Terry Fagan of the Old Monto. So where Temple Street was the biggest red light district in Europe, back at the turn of the last century. And it was renowned for poverty, for prostitution. The second largest Magdalen laundry in the country was on Sean McDermott Street. And Terry Fagan is a local historian who was in a religious institution, Artane, who grew up in the flats in the Old Monto. And we did the tour of the Old Monto, looking at all the buildings, and every 20 metres someone stopped and said hello to him. So there's still that real grassroots community there. And we talk about HSE and governmental agencies, the non-governmental organisations as well, getting to know the ones in our local community who can provide tailored supports to different challenges. SAIL is a service that supports women who are recovering from addiction, but they also have a childcare service. So knowing about that for a child who comes to us who might need childcare support, or even just need that exposure to other children from a developmental perspective, knowing what's in your local area is just an incredible resource. Trauma-informed care is something that I'm learning by experience. We've done some training in it, but it's about asking their story. It's not saying, why are you here today? It's saying, what has brought you here today? What's brought you to this point in your life that you're here with our clinic, with all of these challenges? And it's recognizing that that's to be navigated sensitively. And sometimes people, as you said, you might need to develop that relationship of trust. I meet with our operations group in the hospital sometimes, and they would say that I don't have as high levels of discharge rates as some of the other general paediatric clinics. I'm like, well, that's because 65% of the children in my clinic don't have a GP. And things that are very appropriately managed with a general practitioner is not possible for these children. My average rate from seeing a new referral to discharge is 2 years. But I'll say I discharge them with the problem resolved with education. And there's a Safety Net is a group that provides primary care to those without medical cards in Dublin. It's a phenomenal resource, but there's a lot of sessional GPs. It's not the same as having an assigned general practitioner who knows your story and knows your family. So we keep them on, because knowing that discharging to a GP when you don't have a GP, that's not a safe discharge plan. As well with homelessness, I have a little boy who he just needs an annual urine dipstick and a blood pressure. That's all. But he's living in Gardner Street at the moment, and his GP is out in Lusk, which is a 50-minute train journey away, and then the GP is another 50-minute walk from there, and this is a Roma mammy with 5 children. She's not going to go to that GP once a year. So we bring him in to the clinic and we do his urine and we do his blood pressure. The social determinants of health, I won't spend too long. We all know what they are. And we know a lot of them are beyond our control. They're local, national and international policies that impact people's health because of legislation and things beyond their control. We look at transport, we look at housing, we look at education and employment. And they're all things that we cannot control, but if we recognise it's a problem, like affordable prescribing. I never got trained in affordable prescribing all the way through my undergraduate and my postgraduate paediatric training. No one ever sat down to me and said, this is the drugs payment scheme. This is how you check if a medicine is reimbursable on the medical card. This is the long-term illness scheme. And I know it sounds bananas, but I'd be off writing amazing prescriptions. In hindsight, none of those children probably got those medicines on a sustained basis because I didn't understand all of the different hoops you have to go through to get a medicine reimbursed on the medical card. One of the key moments before, Sarah and I like to talk, I'm delighted I have a lot of time today, and please ask questions while I go. But I remember before we started the Lynn Clinic, I was at a conference in Croke Park about epilepsy. And there was this young man, I think he looked about 12 and was on his second PhD, but he was talking about the genetic advances in epilepsy and all, and I was, bamboozled, couldn't even understand half the slides. I was like, this is so amazing, and all of these targeted, very expensive genetic therapies. And then the next person who stood up was this pharmacist from Edinburgh, where they have all the electronic prescribing and can keep track of everything. And she was giving an overview of medication compliance in epilepsy and said that 30% of children didn't even collect their medicines. And I was like, on one hand, you have this phenomenally expensive, amazing, we're pushing past every barrier and every boundary in medicine in terms of genetics and rare diseases, and yet 1 in 3 children with epilepsy aren't getting their medicines. So there's something that we are missing as a profession if we can't find somewhere in the middle between these advances in therapies and yet basic compliance and affordable prescribing. Intersectional marginalisation is something that I find fascinating and that I'm learning about all the time, because we talk about, one size does not fit all. And the needs of, for example, a Palestinian family who've recently arrived in Ireland seeking international protection, who've come from a horrendously traumatic and ongoing conflict, is very different to a young boy born in the inner city whose mum might be in prison, whose dad is dead, is very different to a Roma family who might be second generation but still really struggling with poverty. So there's no one size fits all, and I think you have to be able to be a little bit flexible in your expectations and also your management. Even things like booking fasting bloods 2 weeks ago for a young man, an adolescent who's quite obese. And then they didn't say anything in the fact, a lot of people don't ever want to argue back to a doctor or feel like they're being difficult, especially if they're in quite a vulnerable situation. They don't want to seem like they're pushing back. And then I just realized it was Ramadan. And I was like, oh my gosh, I'm not going to bring this young boy in fasting for bloods first thing in the morning that he can't eat till the evening, but they didn't say anything. So it was, you have to just try and be that little bit culturally competent and understand different limitations. Social prescribing, so that's non-medical prescribing, and it's about there's a social prescriber in Summerhill, but it's also a lot of NGO organisations and supports. So a couple of years ago I met this little Roma boy who had a very unusual gait and was referred to us because he had pain on walking and difficulty walking. And we got him in. Parents neither had ever been to primary school, very low health literacy and education levels. But we managed to get everyone who needed to see him, our neurologists, our neurodevelopmental physiotherapists, and he got a diagnosis of what was a congenital myopathy, a kind of muscular disorder, but that thankfully wasn't going to be progressive, but he was never going to have much stamina in terms of his walking for long distances. And we did a huge amount for that family. You're kind of at the stage you're going to pat yourself on the back and think, we did a great job here. And we got him linked with the CDNT. We got a huge amount sorted. And I remember about a year later, I was seeing him to discharge him because he was linked with all the services. And I asked the ma'am, and what was the most help to you with the management of your young boy? And when I'd met her, she was 5 months pregnant with her second. And over the course of that time, she'd obviously had her little baby, and she said getting a double buggy. Because we'd asked the Focus Ireland care workers, because she was having to get 2, sometimes 3 forms of public transport to his various different appointments with a little baby and a 3-year-old who couldn't walk more than from here to the end of this room, physically couldn't. And while we were getting the OT and all the bits from the seat, because, he was on the wait list, before they could get more tailored mobility supports, the double buggy was the reason she actually attended. And if she hadn't had that, I'd say her engagement and her attendance would have been almost non-existent, because we wouldn't have supported her to make it to those appointments. So those things can be, to my mind, just as important, as I said, the medical therapies that we prescribe. We all know about adverse childhood experiences, and I think we all know how significant they are in the population of children living in homelessness or without secure accommodation. I somewhat naively, when I started this clinic, was going to do like a screening tool and a tick box exercise as to see how many adverse childhood experiences they had. That stopped. Yeah, you're laughing. It was naive, because they all, like every single child we see, has minimum 4, some of them 9, 10. Their lives, they have experienced more in their short lives than I hopefully will ever experience in mine. And that's worth bearing in mind, because when you're looking at managing an immediate health problem, you're looking at the adult and the person that's going to emerge from that. And I think the adverse childhood experiences is something that societally and nationally we've a long way to go on, in terms of both identifying and addressing, not just as medics, but as health and social care professionals. The allostatic load is a very interesting concept, and it's about the combination of physiological and psychological stressors that actually lead to earlier onset disease processes and chronic inflammation. And we see it in the adult populations. I know Dr. Tara McGinty's here from the Mater, so I'm going to paraphrase a little bit and probably get it wrong, but frailty in the adult inclusion population is much earlier onset and much more obvious and debilitating than their peers. And I remember I did a week in James's Hospital with Professor Nicalig, and just did a ward round with the inclusion health team. And in a hospital, your average age of inpatients is usually upwards of 70 or 80 in a big, busy acute hospital. On the inclusion health inpatient team that week, the average age was 33. And in my head, I did the maths, and I was like, so they've been a child longer than they've been an adult. And yet they're in hospital with really complex, chronic and difficult to manage pathology. So that was a real eye-opener for me, and that we're missing the boat if they're being admitted at 33. If most of their lives should have been within paediatric and early and childhood services, we have missed something here. And integrated care is something we all talk about, and I'm going to show you a little bit later what I feel real integrated care is and how we make it work. But it's talking to you, Shirley, about what do we do. There's a problem here. And I think getting to know people, getting to know interested people who work in this field across the country and taking on different ideas, that's how we build functioning integrated care around populations who find it very hard to actually get into the care in the first place. Once you get them in, you have to wrap around things. So it's very easy to talk about a crisis, that we're in a crisis. And I think it's really important to point out that that is not new. We are living, I think, in unprecedented times, but there's always been social exclusion, homelessness, children experiencing poverty is not new. And you go back 100 years and we were still very much in the aftermath of the Great Famine. We'd had population decimation and mass emigration with economic collapse. We had come through our own conflict in terms of the War of Independence and the Irish Civil War. Huge institutionalized exclusion, which I still see in the children I see in clinic today, whose families and direct family members were impacted by the mother and baby homes and religious orders, and I suppose on those living outside the norms in terms of LGBTQI populations. So none of this is new, and I sometimes think I like to think sometimes you're being innovative, but actually it's history repeating itself. And I think it's also quite a positive thing, because we know we can change, and change has happened before. It was also a time of poverty and a pandemic in terms of influenza, especially in the inner city tenements of Dublin, and we had the highest infant mortality rates in Europe. In Dublin in 1913. I think it was 141 babies per 1,000 died per year. So it was the highest in recorded figures in Europe. So I suppose this challenge and this almost feel of panic that things can be overwhelming, it's not new, it's happened before. And things have progressed, and we've managed to do things. So the Lynn Clinic is named after a personal hero of mine, Dr. Kathleen Lynn, who I'm sure you've all heard of. And she was an incredibly impressive woman. She was in common a man. And she took part in the 1916 Rising and had to flee to the UK to escape persecution, and was under threat of a life prison sentence or potentially execution if she returned. But when the Spanish flu pandemic came, she came back to Ireland with that threat hanging over her, because she recognised that it was the women and children of the slums and the tenements of Dublin who would disproportionately die and be impacted by this pandemic. So she came back, and not only did she come back, but she set up a hospital. She said, there's a problem here, we can do something about it. And I don't know how much permission she asked before she did it. I don't think she's a lady who probably asked much permission. But she set up St Ultan's Hospital for Women and Children, which was our first national hospital to kind of perform targeted care for mothers and young children and infants. They set up the first BCG vaccination programme in Europe, and they really focused on nutrition, I suppose, as part of the management, which was quite novel at the time. And they managed to reduce the mortality rate for children in the hospital within the first year of operations from 55% to 38%, which is no mean feat, given the limited resources, the lack of antibiotics, and the lack of actual effective medical treatment at the time, by just focusing on trying to mitigate some of the effects of poverty. So I suppose it's been done before, we have national precedent, and I think it's really encouraging, because it can be really easy to get discouraged when you're seeing children and families suffering so much and experiencing so much adversity every day. And I think sometimes one of the hardest things to do is to stay positive. So I think we really have to be encouraged that this has been done before. Everyone in this room is trying to do something similar and promote change and innovative practice. So it's something to be really positive about. On to my next slide, which is less positive. So I sat down at the dinner table one evening and just did a kind of mind map of all the different global, local, national challenges that I think would impact the children and families coming to see us in clinic. And the first thing I saw when I looked at it is the bigger picture things that I might be worried about for the future of my own children, like climate change, energy crisis, cost of living, you know. The parents coming to the Lynn Clinic aren't worried about climate change, they're worried about feeding their children that evening. And I have a lot of, I think about 60% of the children coming to the clinic at the moment are international protection applicants who obviously don't look Caucasian or Irish. And I see a huge amount of obesity. And I remember asking one mum, do you ever bring them outside? And she said she used to bring them to Diamond Park, which is just off Gardiner Street. They've done it up, it's a gorgeous park with a kind of multi-tiered playground, it's great. But she doesn't bring him anymore, because after the riots in the inner city in 2023, every time she went outside, they were racially abused. So she'd nowhere to bring her son to exercise. Do you know? So this is the real, that's when you talk about racism and marginalisation, she can't bring her 4-year-old son outside for a walk or to the playground. We look at historical trauma, and with that population I think of the Roma community. And I'd never really worked with the Roma as a specific population group before I started this clinic. And it's interesting, we always say that you can mirror what's going on in the news with what's getting referred to the clinic. Like 2 years ago it was, I'd say, about 50% Ukrainian beneficiaries of temporary protection. Now that number has gone right down to below 10%. But year on year, 1 in 4 children referred are members of the Roma community. And it really speaks to the persistent and consistent isolation and exclusion that they experience. And when you do a bit of digging, you realise why they find it so hard, in particular, to engage with medical care. So the Roma were victims of, the Roma and Sinti population were victims of the Holocaust. And because they weren't well recorded in population censuses pre-World War II, they estimate between 500,000 and 1.5 million were killed. And it took till 2015 for them to be recognised as victims of the Holocaust. And they were also, not only were they selected out for extermination, but Roma children were preferentially selected out for medical experimentation by Dr. Mengele. So I think recognising that, and that's within living memory of some of the elder in the community, and recognising that, and recognising that also for a lot of Roma families, coming to medical care puts you under the radar of TUSLA and social services, makes it a frightening experience to come to a healthcare setting. 2 of the nurses, the CNMs on our team, they're phenomenal, they're warriors, but they have between them 40 years combined experience in A&E. And you'll hear Brigitte speak about working in Temple Street A&E for nearly 20 years and talking about how difficult she would find it when a Roma child checked in for triage, because she said it was always going to be adversarial, it was always going to be conflict and shouting and standing, and she said her heart would just sink whenever they came through A&E, because also she knew they'd probably leave before they were seen. And then they'd have to go and ring and the community liaison officer, and they'd have to send a social worker for it, and it would just create a lot of work for staff and be a big rigmarole. And now that she is seeing the families in a clinic where it's a familiar setting, we have interpreters available then and there. We also now have gotten to know a lot of the local Roma families, and we know, I had a little girl with neurofibromatosis come in, and she brought her sister because she was worried about her sister's kids, so they just brought them along to clinic. And I was like, isn't that brilliant, though, that she actually felt that she could, she wasn't going to be punished or she wasn't going to be given out to. And the child absolutely clearly did need to be seen. There was significant developmental issues. So it wasn't about, and I know the other thing was if we'd said, we can't see you today, come back, they wouldn't have come back. So we just make, you just make it work. Even if it's absolute chaos and there's too many children and you don't have an interpreter, you make it work on the day and you can figure it out. So, sorry, this is a slide which speaks very clearly to me as a parent. So I like to think that I'm Tom Hanks up in the left, every day on a Monday morning. By Friday morning, me getting the kids out the door is very much the bottom. And I have a house, and I have a job, and I have a supportive partner, and I can afford to feed my children healthy food, and they can do their extracurriculars, and sometimes I feel very much like the bottom Tom Hanks. And that's when I wonder, how do these parents do it, these parents and caregivers? That pyramid is a kind of a flip on Maslow's hierarchy of needs, but it's very much the needs that a parent has to provide for their child. And you can imagine a lot of the children I see, their physiological needs are just about being met. And the parents and caregivers come in feeling like they're failing. There might be a child with huge behavioural challenges, may or may not have underlying autism spectrum disorder, but they've moved 10 times in a year. She's a single parent. You're not going to be able to tease it out, but she's keeping the child warm and fed. And they feel like they're failing, and you actually have to go, the fact that you're managing to do this at all is actually a success. And I think, as a parent myself, I think the two things you feel that you have to do for your child are provide them with a safe place to sleep and food. And if the ability to do one or both of those is taken away from you, it's such a fundamental, visceral feeling that you're not meeting your child's needs. So to actually sometimes just acknowledge, by virtue of the fact that you're just about managing to meet their basic needs, is a huge success. I think you have to flip it. You have to change your lens and go, you're doing really well here, and I don't know if I could do the same in your situation. We all know the figures. So this is the picture there is of the old Monto. This is an older headline. We know you referenced the figures there. The numbers are just going up and up every day. And I have an issue myself with the number of children in homelessness only being that of children registered homelessness within city and county councils, because I think we should also be including the children within the IPAS system in that number, which increases it 4 or 5-fold, because they are all in similar infrastructure, repurposed industrial facilities, hotels, and congregated settings. Even something as simple as looking at the north and the south side of Dublin. South Dublin has more trees and green spaces, and you look at the environment of where you're in, where we do the clinic in Summerhill. And I know there's members of the social inclusion team who work there. We had the Minister for Public Health who visited last week, and I was kind of joking, going, which pharmacy will we show her? Will we show her the pharmacy on the right or the pharmacy on the left? And I can tell you the pharmacy on the left is the one with the queues outside it at lunchtime with 14-year-old boys queuing up and dealing drugs in broad daylight. And these are children. And I see about 50% of the children I see are under the age of 5, but I'm seeing their future. And that's when I feel I'm only a doctor. What can I do in terms of impacting their future? In that way, not much, but it's talking to the other organisations and bringing all those other things together. So I don't know what's happening. That's how we make a difference. Because I said the medicine is the easy bit. I can treat iron deficiency anemia, no problem. But how do I stop the beautiful 3-year-old who's in front of me throwing his Bics around in 10 years lining up outside that pharmacy or dealing drugs at that pharmacy? And that's the question I ask myself. So we've talked about the intersectionality, I suppose, the homelessness, we talk about forced migration. We do have a number of children from the Irish travelling community as well, and that tends to be, there's quite a lot of support infrastructure in North County Dublin, up St Margaret's Road, which really does support a lot of the travelling communities. The children I see it's a lot of single traveller women who've entered homelessness because of domestic violence, and because of that are quite isolated from their families and support infrastructure. And I think it's really interesting that a huge amount of the Irish nationals who are homeless are because of domestic violence as well. So can you imagine being a parent faced with the choice that if I leave this abusive relationship, this is what I'm entering into? It's a choice nobody should ever have to make. And again, I've referenced the Roma community, and I think that the one thing, the unifying factor there is, do you know what, it's such a pleasure and a privilege to work with these families, because you're seeing them at such a time of difficulty in their lives that I think we have to look at our role in this as a privilege, that to be able to be afforded the opportunity to build a relationship of trust and to get to know families and to ask some really difficult questions, which I'll go into in a little bit, that's a real privilege. And it's actually something in the rest of my practice, when I'm doing a busy ward round, you know, with a child who's admitted with, you know, maybe a seizure or an infection, you actually don't get to do that so much anymore, because hospitals are so busy, or you've stuck to time, you have to discharge people, there's bed flow issues, and actually it's so nice to sit and get to know people and to really understand their lives. And if you don't do that, how can you manage to support them with managing children with sometimes very complicated and serious medical conditions? So I suppose this is where the integrated care piece is. We cannot, it takes a village to raise a child. You can't do it alone. I couldn't do my job, number one, without my team, but also without the myriad of services that are in our local area. So in the hub where the clinic is, there's a Roma health clinic 2 days a week, and we know the team who work there, they send referrals into us. So I don't wait. If I waited for a GP referral, I wouldn't have a wait list. I'd have the most successful outpatients clinic in the country, because I wouldn't have any patients coming. So we take referrals from anybody who encounters these children if we're worried about them. And what we try and do is we do try and direct towards primary care supports, but again, see them in the meantime while you're sorting all that stuff up, because children don't get this time back. And time wasted in going through all of the, I suppose, the traditional infrastructure, if you have a child who might have cerebral palsy or seizures, is time that they're not going to get back, and you're going to end up with a child with a more severe presentation of disease. So I think structured integrated care, the biggest thing that we have is actually our relationship with our peers. So for example, one of the neurologists in Temple Street really understands the challenges of being homeless and affordable prescribing. And I had a child come to me in clinic who was having multiple seizures, had been tried on many different meds, was currently on no meds. And I know even for the urgent neurology, it's still 6 weeks before they can get to a clinic. And I was like, I can't leave this. And you also don't want to admit a child to hospital. So I rang her, gave her the story. She gave me the epileptic to try. We started him on it. His seizures settled down. And she did see him within 6 weeks. But in the meantime, we've avoided an unnecessary hospital admission. I've got the help of somebody who knows more about this area, and the family were supported, because what I try to practice is, yes, you can bring children into hospital and manage things, but you're not fixing any of the environment. So unless you really have to, and also bringing a child into hospital if there's a single parent with 4 other children and they're living in a hotel room is a massive ask. So if we can manage around that, I think over the last 4 years, I have, versus an emergency unplanned admission, I've only had to admit 9 children over the last 4 years, because we do everything, and we talk to the public health nurses, we talk to the community medical doctors, we talk to primary care, we talk to the NGOs, we get support workers, whatever we can to keep these children out of hospital. So it's not just about integrated care outside the hospital, but integrated care within the hospital, and people being amenable to discuss things. And there's so much goodwill out there when you actually talk to people. I also find, I don't know, it's much harder to say no when someone's talking to you on the phone or in person than an email. So if I feel something's going to be a little bit tricky, I'll show up at their doorstep. I think people have me on their phone as do not answer anymore, but it's fine. I look at it, you have to kind of knock on the doors and ask the difficult questions. And what's the worst that can happen is someone can say no. And I think keeping it holistic and child-centered and focused. So one of the things about because school is so huge for these children, it's the only constant in their lives. So our clinics are in the afternoon, because trying to get, Finstown Castle is out in Lucan, and I have a lot of families there. It's an hour and a half by public transport to get from there into the inner city Dublin, and if they have 3 other kids to bring to school, they can't bring the other children to school because they won't be back in time for collection. So very early on we said our clinics need to be in the afternoon. And bring all the children. We often get, I can't come, I've no one to take the children. Bring them all. And often you'll go, this one isn't growing so well either, and this one has terrible teeth. So I end up giving all those children hospital numbers, and we bring them back as well. But that's you kind of you go looking for work in a good way, because you lay eyes on children. It's about making every encounter count. So if you have an opportunity, use it. And I think what we're really working, and it's always going to be a work in progress, is that comprehensive bridge of care. And something we talk about is children with complex medical conditions living within the international protection accommodation system. And when they move last minute across the country, we're talking about mapping out a bundle of transfer of care, because often these children either might not have engaged with any medical care, but if they have, they could have been referred to CD&T, they could be in the middle of occupational therapy. I have a young man who's coming in for bloods today, who'll be moving to Sligo hopefully soon. I'm very jealous because he's wonderful and I'll miss him. But to talk to each other so that there's not, you put in a huge amount of work, and then if a family lands in Sligo with no paperwork, nobody knows they're there, nobody knows the child needs, one, what's the point in have done everything? And number two, it's really unfair to have to put them through all of that again. So it's about being able to support them throughout their journey. And we don't have a universal healthcare record, so we do have to take responsibility for making sure the relevant information travels with the child. And some parents are brilliant at that, but I can tell you, if I had to move my family of 5 with less than a day's notice with the child in a wheelchair with cerebral palsy, and I'm not going to remember to bring every piece of paperwork, or that I need to let the CD&T know that we're moving, and also maybe a school placement. There's just so much. I hate filling out forms myself. I'm allergic to them. And I look, has anyone ever filled out a CD&T form? Oh my gosh. I start doing them and I'm like, number one, and I have a 3rd level medical degree and I find them a real challenge. So we do it. We get consent from the families to fill it out for them. And it sounds something so simple, but that's the difference between them getting waitlisted. And I've had some caregivers really try to fill them out, but the parent themselves, the caregiver, may not have been to much in terms of primary level education. And what they're putting on paper just doesn't convey the level of need. So again, we'll get their consent to go, can we help you with that? And we'll always give a medical support letter, but it takes a huge amount of time. It's a lot of our non-clinical admin and workload is filling out these forms, but what's the alternative? That they don't get referred in, and that they wait maybe another 6 months till something happens, and then they're back to the bottom of a 2-year wait list. So even those little steps are probably the most successful things that we do versus the medicine. It's helping with filling out forms. And I have to say my CNMs are better at that than me, because I am a bit still, I get scared by forms. They scare me. How do we do it? So this is our clinical and operational pathway, and I suppose this is what I really wanted to discuss today, because I think there's a real opportunity here in kind of sale to group in this area, because more children are being brought in and put in communal settings. And we've tried things and we failed, and I think you can't be afraid to try something that doesn't work is the first thing. And I think showing I'm a big believer, share information, share what works, share what you've done, because what's the point in reinventing the wheel? But also in getting feedback as well as to, oh, well, have you, we get a rotation of GP SHOs through our clinic every 2 months, which can be you've just gotten somebody ready to go and then they're moving again. But some of them come in with really good insights and different perspectives. So it's great to always have fresh eyes on things. So our referral pathway, as I said, absolutely, we take GP referrals. We get a lot of referrals from our emergency department of children who might have presented 17 times in the last year with the wheeze, but who've never gone to a GP because they don't have one. We get referrals internally. So there was a young woman who did not attend haematology 3 times, but they were worried about her. Her haemoglobin was only 6. So we took her on and we got her into clinic, and it turns out she's a very rare kind of hemoglobinopathy. And so I saw her, got her done, and went to haematology. You actually really do need to see her. I have no idea what I'm doing. But we got her in. So specialists who identify children that they're worried about who aren't coming will call us, and we'll be the gateway then into the subspecialist services. As I said, Safety Net Primary Care, we have a great relationship with their migrant and their Roma clinics, and they refer into us. And a lot of the community health and social care professionals, so the PHNs of the North Inner City, have us on speed dial. And I'm delighted, because it means they know that there's some route into hospital care through us. Now, our wait list is getting longer, but equally, if somebody who knows these families say they're worried about a child, I take that really seriously. Similarly, the GP practice in Summerhill, they have 2,500 people on the medical card. They know what poverty and deprivation looks like. If they refer me a child and say they're worried, I'm worried. Do you know what I mean? I don't need to read between the lines or scour the referral. If it's flagged that they're worried, we will see that child within 6 weeks. I've had referrals from Pavy Point, from the Roma peer support workers there who went into a family hub. And a mum said she was really worried about her child, about his heart problem. And they'd been in the country about 18 months, no GP, not in hospital services. This child had a partially repaired complex congenital heart condition. And again, Andrea dropped me an email and I said I'd arrange to see him, because if I was going to wait for him, and getting that mum, she'd 4 other children, one of her other children had complex neurodisability, getting her to register with the GP to get a referral to then come into us, we would have wasted about 6 or 9 months. That child needed urgent surgery. So take the referrals, pick up the phone and just be flexible and be open and accessible to anybody who is working with these populations, so that they feel, and it's a reciprocal relationship. The public health nurses do a huge amount for us if we ask them to, because they can actually go in to the homes and the hubs with a lot more than we have the capacity to. So it's very much a symbiotic relationship. I suppose the biggest piece of work, usually all the work happens after clinic. For us it happens before the clinic. A phone number, a contact number for a parent can change 3 times in 6 weeks. And the amount, the Sherlock Holmes level of digging to find a child and to locate them and to make sure they're aware of the appointment is Trojan work. And I'm incredibly lucky to have very skilled admin who can navigate that. And, will nearly always be able to, if we can't find a child, the majority of the time they have left the country. But we'll link with IPAS if there's a child we're worried about and we can't find them. So we will always we'll leave no stone unturned trying to find the child to get them to clinic. It's an informed triage process in terms of you don't just look at the presenting complaint, but the GP, what's their accommodation. I didn't know that 64 Marion Road in Dublin 4 is emergency accommodation. And neither would most people looking at a referral letter. So you need to know, and the addresses are always changing, but knowing what actually represents emergency accommodation in your triage is really important. As I said, proactive liaison, linking with community support workers. Mr. Danut Nye of the National Roma Helpline is an invaluable resource for us. He will relay messages for a lot of the Roma population who aren't literate in either English or Romanian. He will pick up the phone and relay the message to them in Romani so that they understand. So again, it's a real proactive confirmation of attendance and supports. Telecommunication is brilliant. Like letters, again, are just so confusing. You look, CHI, even our hospital, because we're different sites, the letterhead is CHI, and then in tiny print it says Crumlin or Temple Street. So I've had children who were supposed to be at a very precious GI appointment in Crumlin arrive in Temple Street because they saw CHI. And like, if I didn't work in the place, I'd probably do the same. So we use WhatsApp, we use Telegram, we use social messaging to engage families. The other thing was, when we started, we used to send normal SMS texts, and people wouldn't write back for days, and it's because they didn't have credit. So at least when they have access to free Wi-Fi, they'll reply. So it's really basic things like this to be aware of and to navigate. And supported attendance. If there's a family where it's really difficult for mobility or other logistical things, we will get a taxi for them to get into clinic. Because again, to me, the cost of a taxi to get them in to have a holistic comprehensive care assessment is money well spent to do that preventative piece before the child lands unwell with refractory seizures in A&E. So I said the OPD review, I'll talk about a few of our clinical considerations, but it's much more. We spent so much time on the kind of other pieces, the social history, the background, the support, so medical card, have you a PPS number, what benefits are you receiving. We spend an hour on new referrals in the clinic because you need that time to gather all that information. We try and practice trauma-informed care with as much, we'll all make mistakes, I'm learning every day, but with as much cultural competency as you are able to navigate. We do a huge amount of opportunistic health promotion in terms of giving out information about healthy lunch boxes, the food pyramid in a basic format that doesn't have too many words, oral health promotion. There's a dentist who sees the children and siblings across the road, so we send them from clinic over to get their teeth checked, because to me, dental decay is the biggest physical indicator of poverty. And the reason the dentist sees the children from our clinic is every single one of them needs multiple teeth extracted. So it's unfortunately, a very high yield clinical interaction for them. And especially with a lot of migrant populations, these children do need sickle cell screens and communicable disease testing prior to any big surgery. So we're able to support that and feed into it, or identify children who aren't suitable for extraction in the community setting. We also do opportunistic vaccinations. I'd love to do formal catch-up vaccination. We just don't have the resources, but this time last year, just kind of, I suppose around March, April last year, we started doing opportunistic MMR vaccination, and we did seasonal influenza from October, again looking at congregated settings. And the one thing I found is the vaccine hesitant population, if you you'll get them to consent and agree, you have to have the vaccine there. If you get them to consent and agree and then send them off to the GP, not going to happen. Have the vaccine there, talk them through it, and as soon as they say yes, go. But having it there makes, our uptake is brilliant when it's offered, and we'll do the siblings as well. I'd better just check how I am for time, I'm okay. So then, and it doesn't stop at clinic. So huge amount of community health referrals that we support, and to other agencies, like One Family is a support organisation for single parents. SAIL, supporting addiction services. We have a great relationship with Focus Ireland, which provides support workers to a lot of the accommodation in our immediate area. So it's that intra-agency care piece. I couldn't do what I do without the Focus Ireland support workers helping them obtain their prescriptions, or they wouldn't get the meds. So we do resource signposting, very active follow-up. So I see a lot of iron deficiency, anemia and vitamin D deficiency. And in more general practice, you'd give the treatment for 3 months, go get your bloods checked with the GP, goodbye, discharge. No, we book them back in, we see them again. An iron deficiency, anemia, even if they adhere to the medicine, it'll still take 6 months because we make sure it's treated before we discharge. And then follow-up care, the transfer of care piece is huge. Even within Dublin, the transience between different areas and regions in terms of GP care. We do the repeat investigations in the absence of the GP. I'm doing an audit at the moment of how many children I have to bring in for directly observed therapy, so for iron infusions, because for whatever reason they're not managing to take the high-dose oral iron supplement, and high dose vitamin D as well, which is when you give a very high dose to normalise the vitamin D levels, because again, getting the formulations that are available on the medical card aren't palatable or nice, and they're big capsules, or it's like 20 drops, and that's quite difficult to manage and everything else. So if we notice that a level isn't improving after 3 months, we bring them in, and it's just directly observed administration, and that's been very effective. And coordination of engagement. We coordinate our hospital resources. So a lot of children, especially from a migrant health perspective, we'll do nutritional screen, communicable disease screen. Some of them may need an X-ray or an ultrasound. So we'll coordinate with our phlebotomy and our radiology. And it means that all the work you're doing to scaffold and attendance, at least you're optimising everything. And it's reduced their non-attendance rates as well for these images. So it works well in terms of streamlined use of hospital resources. So I won't spend too long, but just anemia. If you think of a common paediatric clinical scenario that you come across in day-to-day practice, I was referred a child who had come in through the A&E from a hotel with a fingertip injury, and she'd needed plastics to see it, and they'd noticed that her hemoglobin was 7. And plastics had referred to haematology. And the haematologist had looked at her blood film and said, Aoibhinn, I think this is probably nutritional. And, she lives in a hotel. I think she'd probably be better fit in your clinic. And then obviously if you need further help and support, we'll see her. So brought the child to clinic, and yes, she was very anemic. She was from sub-Saharan Africa. It was clearly nutritional. She had all of her teeth were rotted. But then you start peel back the layers and going into the history. So it was a violent conception. The mum had experienced a huge amount of sexual and gender-based violence in her country of origin. Mum had never been screened for communicable disease, nor had the child. The child she had left her country of origin because local elders wanted female genital mutilation or cutting to be done to the child, so she left her country of origin because of that. And when we met the child, she was underweight. Her BMI was on the first centile for her age. As I said, she had severe dental caries. I think ultimately she had 10 teeth extracted. She was also infested. She had fungal infestation of her scalp and on her groin. And so what we did, yes, we treated the anemia, but we were able to link her with the dentist. And when the teeth were extracted, she was able to chew. She started eating better. We started on nutritional supplements as a short-term. I don't have a dietitian, but I would be quite comfortable starting nutritional supplements while you get all the other pieces together, because again, nutrition is growth and cognition at an early age. This child was 4. So we treated her infestation, which meant she slept better, which meant her behaviour was better, and we obviously tested her for communicable disease, and we referred mum to the Rape Crisis Centre where she got her own counselling, and we referred her for communicable disease testing as well. So what looks really simple and common in terms of anemia, when you start to ask the questions and you tease out what someone's story is and what the story inside them is, only then can you really start to treat the underlying causes. Similarly, disability. I get 1 in 3 children I see are referred with developmental or behavioural concerns. Can you imagine being in a hotel room as a single parent with 5 children, 2 of whom might have undiagnosed autism spectrum disorder, who have difficulty sleeping, and that, you know, and you're told not to give them too many screens, but it's the only thing to keep them quiet, because if they start screaming or performing self-injurious behaviour, you're getting bangs on the walls and bangs on the door, and people are complaining to the manager. It's horrendous. So adding any type of kind of neurodevelopmental pathology into a congregated setting is just impossible. And trying to get melatonin to me is magic for these children, just to help re-regulate their sleep cycle. It's not available on the medical card. It's not covered by the drugs payment scheme because it's unlicensed. You can get it under the hardship scheme, but many pharmacies aren't reimbursing it because they're not getting paid back by the state. And you can buy, I know you can buy it on Amazon, but it's not money that these people can afford. And to buy it with prescription, it can be €30 a bottle. And sleep, I've told a few people here last night that I'm a parent of a child who hasn't slept in 8 years. So I really empathise. You take sleep away, you take away someone's resilience and their ability to cope. And I've mentioned faltering growth, but very briefly, it's very easy, you know, eat nutritious food, eat your red meat if you're anemic and your green vegetables. You don't have a kitchen, you don't have a fridge. If you have your own house, electricity is prohibitive. So the common sense and the conservative things that we are taught to do are very condescending and unrealistic, actually, for a lot of the children that we see. And I know another thing I'll touch on briefly is weaning. Weaning in a congregated setting where you don't have access to the food that you grew up with, or the food that you're used to, that's your cultural history. You can't puree. There's a place in Dublin where there's 500 people living where there's 2 microwaves. And I'm bringing in, and then women are breastfeeding for longer. They're also iron deficient and vitamin D deficient. And then they have another baby. So they've to wean the child who doesn't eat, who's developing dental caries because they're breastfed through the night to get them to sleep. And I'm seeing so many, I'm doing a piece of work with public health because I'm seeing really aversive, almost ARFID type pictures emerging. And these are neurotypical children. But they have not been allowed that fundamental right to learn to explore food and to develop a normal weaning and feeding pattern, and we've taken that away from them. And I actually don't have an answer to that yet. There's a huge amount of people invested in improving this, but we're not there yet. But take away a parent's power to feed their child, and I think it's one of the worst things you can do. Just a very brief review. The biggest thing we see is neurodevelopment. And sometimes I'm very confident that it's not actually a pervasive developmental pathology that a child has, but it's a product of trauma and adverse childhood experiences. But again, you have to get them in, you have to do the referrals, you have to try and tease that out and get the child the supports they need in the interim. Just in the interest of time, these are just a few of the clinical considerations that I suppose we have in clinics. So health literacy. I remember seeing a Somali mum and the child was referred in for query hepatitis. That there was this history of had the child had hepatitis, had they not, we didn't know. And I was going through my medical history and said, does anybody have problems with their liver in your family? And she said, what's a liver? And it was just that moment, I was like, number one, I don't know how to explain this, but number two, how are we supposed to take a clear history from her? How can we afford her a high standard of care if we can't support her understanding of what we're asking and what we're doing? Lack of primary care is huge. Lack of supportive and GPs who understand and know a story, a familiar face, is just invaluable. I've mentioned cultural competence in my own recent experience around fasting for Ramadan. Female genital mutilation and cutting is something that start asking about it, and it's there. And I think we don't have a paediatric pathway for FGM or cutting at the moment. And I have a colleague who's just started who is forensic medicine trained, who's come into post, and we're going to try and develop alongside TUSLA and alongside our SATU services, because at the moment the only pathway that's medical legally sound is to refer into our sexual abuse and treatment unit. And I think for some children that's necessary, but it's pathologizing, and it's also being almost persecutorial to parents, some of whom have left the country because that happened to their child, but an FGM disclosure automatically comes with the TUSLA referral. So you're trying to navigate keeping that bridge of trust while also having to escalate through this pathway. And if anyone is interested in it, please approach me, because we're trying to put together a group of people to make this as supportive a journey as possible for these families and these young women. Human trafficking, again, it's everywhere. Lift the lid, start asking the questions, and it's there. Anyone who's come into Ireland via Belfast has been trafficked. I've set up a pathway now with TUSLA for unaccompanied minors under 16, so children who've come into Ireland seeking international protection and who may not come into the country alone but are abandoned alone after coming through customs. and the stories, these young men and young women have been through. I had one man who was kept in a container, sedated for 3 weeks, and was hit over the head with a metal bar when he tried to escape. This is what young people are going through. And I think a big deficit is lack of appropriate migrant trauma supports. And I see these beautiful young people, but I really worry for them in 10 years' time, because at the moment they're in survival mode and they're engaging and they're doing what's asked of them, but I don't think we're in any way starting to address the trauma that they've experienced. That, number one, ended up with them leaving their country and their family, and number two, what may or may not have happened to them on the journey over. And the ones I worry about more are the ones who don't tell me anything. There's still those untold stories inside them, and we'll ask gently and sensitively, but you don't push people further than they're willing to go. And it's the ones who don't tell you what's happened. They're the ones I really worry about. And again, something we really need to look at from a community supports perspective. As long as these children in the country, even if it's not for, and that doesn't just apply to the unaccompanied minors, it's children of families who've come in seeking international protection have sometimes come through horrendous experience, and I think we really, for the time that they are with us, we need to support them. Parental loss is a huge figure, and I don't just mean bereavement, but loss of that parent, be it through drugs, incarceration, or separation. We have a lot of families where the mum and the children are in one setting and the father is in another. And that, number one, takes away that village, that immediate support for the mother, the primary caregiver, and they lose a parent. And a lot for young men, they lose that father figure as well, which we know, looking at adolescence, looking at what's happening with young men in our society, is a real worry, and again, an adverse childhood experience. Forced migration says it itself, and domestic, sexual and gender-based violence, we ask the mothers and the parents. And most of the time, one of the reasons they can't engage is because they're so acutely traumatized and in that kind of immediate cycle of survival that they can't engage. And it's actually one of the biggest and most successful interventions is engaging the parent in necessary services. Because, if a child is constipated, it's okay to wait 3 months, and actually if you support the parent psychologically, you're going to get a much better outcome if they're in the headspace to be able to listen to the instructions on what they need to do to support their child. And as I said, it's not just a lack of a house, it's the lack of a home. So just to finish up, I think nearly half the children I see are under 5. And we're talking about all of these horrible things that they may have experienced before they've even entered school-going age. And that's if there is a school placement for them, which we know is not always an option. But I also, looking at it from a positive lens, we're getting these children in. We have an opportunity, not just as medics, but as professionals invested to make a difference and to intervene. And we have to look at it through that positive lens. These are the figures, I think, from 2023 in terms of what the nature of the accommodation was. So at that stage, it was 73%. And by transitory or emergency, that could be anything from a family hub, which is quite well supported, to a repurposed industrial facility. And I think that's one of the other pieces, is not all emergency accommodation is created the same. Children and families who come into Ireland, who come through Balseskin Reception Centre, are actually very well supported by a HSE team, HSE Social Inclusion and Integration, but others who come straight and might go to a hotel at the Red Cow. It's nice to see what can be done when we have the infrastructure and teams in place, but it's not afforded to everybody because of lack of resources. I said I'm seeing more and more children now under the auspices of TUSLA. This just is a picture, as I said, we reflect the news in terms of what's coming in. So I'd say if I were to look at, I have to look at 2024's figures, but I'd say we're closer to 60% now are international protection applicants or families with refugee status or leave to remain who are still within homeless services. And just, I suppose, it can be done. So we looked at a 12-month period of attendances to our new referrals clinic. And with all of that scaffolding, support and liaison in place, 85% attended their first appointment. Now it reflects a huge amount of work, but then second offered appointment, that brought that figure up to above 90% attendance, which when you look at the demographics and the breakdown of the populations that we see in kind of hospital services in Ireland, the OPD attendance rate is 1 in 8, is 12%. So we're exceeding those figures in groups that notoriously and historically are the ones much more likely not to attend. And I suppose getting testimonials from the people in the community, because I don't see our clinic, it's a hospital clinic, but I would hope that we see it and we're seen as being part of the local community as well. And one of the local GPs, without this service, I have no doubt that the children who have been helped by the Lynn Clinic would have slipped through the cracks, leading to much lost potential later in life. And that's what we're not just looking at medical outcomes. We're looking at the life of a child and their potential, whatever that potential may be, and that's what we really have to try to support. One that really, really warmed my heart was families feel understood and welcomed at the Lynn Clinic. And when that Roma mother, who I've had, we've had some heated exchanges before, but we always end with a smile. When she felt it was okay to bring her sister and her niece in, that to me was huge, that she felt safe to bring her sister and her niece there, and that we saw them. It was a crazy clinic. I really could have done without it, but we made it work. The Lynn Clinic staff understand the challenges that our patients face, such as homelessness and unstable housing, food poverty, poor health literacy, intergenerational trauma, family background of addiction, incarceration, or major mental illness. And you have to take them into account even before something as simple as a prescription for iron supplements or constipation if you really want to see a successful outcome. It's not about gold standard medicine. It's about what is feasible, sustainable and practical for a family. And you're going to have much better outcomes if you focus on that versus your gold standard aims. So these are some of the organisations we interact with on almost a daily or weekly basis. So the child and the family is always at the centre. We have our hospital networks, and not just our own hospital, but regional and local infrastructure. As I said, if I have a child with complex need transferred out, I'll contact the local paediatric unit, send on the records, let them know. Again, acute and community base, interdepartmental as well, but NGO and community are a huge support in terms of advocacy, cultural support. Akida have been really helpful for us and the Irish Family Planning Clinic to upskill around the female genital mutilation and cutting piece. HSE in terms of the health regions, acute operations, public health. What I want to practice is prevention. I need my public health colleagues, and they've been wonderful in supporting us as to how we do that. And we can help them with our learnings around growth and nutrition and developmental impacts. Dentistry have been phenomenal. The disability services, to be fair, the disability services are overwhelmed, but when you approach them, they're great at even discussing things as to, okay, we can't do this right now, but we'll suggest this, let's do this. There's people at the end of the phone are brilliant. And as I said, our primary care colleagues and public health nurses. But there's the Department of Children, and we all know the direct provision system is not fit for purpose, but similar to a lot of aspects of the HSE, the people working on the ground day to day supporting these families really want to do the best by them. So knowing them, I have a meeting every month with IPAS around children with medical complexity within IPAS services to try and support them and identify needs that should be met even while they remain in IPAS. Too sly, I have on speed dial, but we have a very good relationship around not just supporting child welfare and protection concerns, but pathways of care. Local councils and housing officers, special educational needs officer and educational welfare support school. You can manage everything. If a child can't get to school, we're not supporting their mental health and their development. And again, we're always pushing towards professional education, research and government. So we are designing an inclusion health curriculum for RCPI. I'll talk to anyone, anytime, ever. But it's about spreading the word. And people actually love to hear about this and that there's a different way that you can do things as well. And this is from Professor Michael Marmot in the UK. But I just find this graph so simple and so sombering that when child poverty increased in England over a decade, infant mortality increased. And it's such a simple statistic, but it's really scary as well. And I think Dr. Martin Luther King, of all forms of inequality, injustice in health is the most shocking and inhuman. And I think when we look at children, we all have a responsibility to do, and if you're not the person who can help, try and find out who can. Often I'm not the right person to do something in terms of a housing issue or a school issue, but I will take it upon myself to find out who the person is. So that, and whereas, you sometimes might have, no, sorry, that's not our area. Well, then who is it? Who can I talk to? Who can we ask? And sometimes I also, a bit of persistence. I've had a record of 3 rejections for CAMS for one patient, but I got them in on the 4th. And sometimes it's just about a bit of tenacity and a bit of perseverance. When a family can't advocate or persevere for themselves, sometimes taking on that piece as well is really important. So to finish up, I suppose, what is our key current priority? Structured service development. There's interested paediatricians around the country. We formed a network because, again, we want to structure something to inform a model of care and evidence-based practice. We want to expand our own team while also supporting the building of regional hubs. We want to support research and evidence-based practice, and we will hopefully be pulling together a lot of our data soon. I would love to, and it's something we haven't had time for yet, but I really want to incorporate service user input, talking to the parents and caregivers of the families that we see. I would love to see a Roma peer support worker employed by Children's Health Ireland. I think that would be transformative. And I really want to expand and formally map out the integrated services that I've referenced. So thank you all for listening. And I'm happy to take questions now or at the panel discussion at the end. I suppose we're probably...
Yeah. I think... people, and I'm sure people have lots of questions, so we'd hold them for the panel discussion, and people can maybe just take a note of them, and then we get through the panel discussion.
Thank you so much.
Okay, thank you. I think that was really informative, and I know I could have sat here listening all day, so it was really, really interesting. So we're going to have a quick tea break now for 15 to 20 minutes. So the tea coffee will be outside, and if we ask if everybody is back here at 10:35, we're going to show an audio clip straight away when we come back. So if people are just back here by 10:35, and we'll start it back then. Thank you.